Are your annual wellness visits secretly acting like a ticking time bomb for your practice's revenue? I mean, just imagine opening up a letter only to find a massive recoupment demand, all because your commercial and Medicare preventative codes got completely tangled up. The stakes for incorrect billing in preventative medicine are incredibly high, and honestly, that dividing line between routine care and problem-oriented visits, that's exactly where most billers get trapped. Hey everyone, I'm Harshal, your resident medical coding instructor, and today we're going to bulletproof your coding so you get paid correctly the very first time, totally free of that audit anxiety.
Welcome back. Today, we're bringing you a highly specific explainer focused entirely on preventative medicine and those notorious Medicare annual wellness visits. If you've ever stared at a super bill wondering whether to use a standard EM code, a preventative code, or somehow both, well, you are in exactly the right place. Okay, let's dive right into this. Today's roadmap covers commercial preventative medicine codes, decoding Medicare wellness visits, same-day dual billing rules, preventive risk factor counseling, and finally, audit guardrails and compliance. All right, kicking things off with Section 1, Commercial Preventive Medicine Codes. So, first things first, it is absolutely critical to understand that commercial codes function entirely differently than your typical sick visits. For commercial payers, preventative service codes are split right down the middle based on patient status. On one side, we have the initial preventative exam codes, running from CPT 99381 to 99387. Now, these are strictly for new patients. That means the patient hasn't received any professional services from you or your same specialty group in the past 3 years. On the flip side, we have the periodic preventative exam codes, running from 99391 to 99397, and these are for your established patients. Both of these sets require a comprehensive, age-appropriate history and physical exam, along with developmental guidance and risk factor reduction counseling. Once you've got that new or established status figured out, your very next step is looking at the calendar. Why? Because these codes are strictly age stratified. Just looking at the established patient brackets here, the progression is super straightforward. An infant under 1 year is coded as 99391. Early childhood is 99392, and then it literally just steps up chronologically through late childhood, adolescence, young adults, middle adults at 99396, and finally adults 65 years and older land at 99397. This exact same chronological progression applies to the new patient codes too, they just start at 99381 instead. And this brilliantly illustrates exactly what we're talking about straight from the CPT manual. The established patient headers explicitly dictate these age ranges. Notice the specific language being used here. These are for the reevaluation and management of an individual, and that includes counseling, anticipatory guidance, and ordering appropriate labs. This is routine health maintenance, guys. It is not for managing an acute asthma attack or evaluating some brand new undiagnosed pain. Moving right along to Section 2, Decoding Medicare Wellness Visits. Okay, you know everything I literally just said about commercial codes? Yeah, forget it, because Medicare absolutely does not play by those rules. Medicare has a highly specific, time-sensitive framework built entirely on HCPCS G codes. Here is the strict timeline you basically need to memorize. When a beneficiary first enrolls in Medicare Part B, they have a 12-month window to receive their initial preventative physical examination. We usually call this the IPPE, or the Welcome to Medicare visit, and that's coded as G0402. After they've been enrolled for 12 full months, they become eligible for their first annual wellness visit, or AWV, using code G0438. From then on, after that initial AWV, they can have a subsequent annual wellness visit every 11 full calendar months, which is coded as G0439. So the absolutely crucial point here is navigating these tight timelines. You cannot bill an initial AWV within 12 months of that Welcome to Medicare IPPE. But, and this is a major point of confusion for a lot of billers, people wonder if the IPPE is a mandatory prerequisite. It's actually not. If a patient totally misses their first-year welcome visit, they can still get an annual wellness visit later on once that 12-month mark passes. Plus, you've got to remember these visits aren't your typical physicals. They focus heavily on health risk assessments, depression screening, end-of-life planning, and creating a personalized prevention plan. And just to reiterate, commercial codes like 99397, they are statutorily excluded by Medicare for routine checkups. Do not mix them up. Let's hit Section 3, Same-Day Dual Billing Rules. This is where it gets tricky. So what happens when a patient comes in for a routine checkup, but say their hypertension is completely uncontrolled and requires a medication adjustment right then and there? Well, you can actually bill for both, but you must follow a very strict sequence to justify medical necessity. Step 1, you perform the scheduled routine preventative assessment. Step 2, during that visit, you identify a significant, separately identifiable, acute or chronic problem that requires extra work. Step 3, you perform and document a distinct problem-oriented EM visit, like your 99213 or 99214. And finally, Step 4, you append modifier 25 to that problem-oriented EM code. That modifier is basically raising its hand to tell the payer, hey, yes, we did a wellness visit, but we also had to do significant extra work to treat this specific illness. Now, looking at the exact CPT guidelines, different diagnoses are not explicitly required to use modifier 25. Though, let's be real, they definitely help paint a clearer picture. What is absolutely required is that your documentation clearly shows the extra work. If you're billing a 99214 alongside a wellness visit, your note better clearly separate that routine checkup from the complex medical decision-making you did for the acute problem. And please, remember patient communication here. Preventative visits are usually totally free for the patient, but the very moment you bill that sick visit with modifier 25, it's going to trigger their copay or deductible. You have to let them know so they aren't completely surprised by a bill later.
Section 4. Preventive Risk Factor Counseling. Let's briefly shift gears. What if the patient isn't sick, but they really need focused behavior change intervention? These codes, specifically 99401 and 99402, are purely time-based. They are used for promoting health and preventing injury for patients who do not currently have a specific illness that you're treating. So, for example, if you spend 15 minutes counseling a healthy patient on diet, exercise, or injury prevention, that triggers 99401. If it takes roughly 30 minutes, you'd use 99402. The absolute key takeaway here is that the time spent providing these specific counseling services cannot be double counted to boost the level of a standard EMM office visit on that exact same day. Finally, Section 5, Audit Guardrails and Compliance. Listen, making a mistake with these codes doesn't just mean a simple denied claim. A pattern of mistakes can trigger a massive audit. We really have to distinguish between fraud and abuse, as outlined in our source guidelines. Medicare fraud is when you are knowingly submitting false claims to obtain payment you just aren't entitled to. Medicare abuse, however, is often where well-meaning billers get caught up. This involves misusing codes on a claim, like upcoding a visit or unbundling services that should have been billed together. Both of these carry severe financial and potentially even legal penalties. If you want to stay off the auditor's radar, and trust me, you do, avoid these top red flags like the plague. First off, auto-billing a 99214 with every single annual wellness visit is an immediate algorithmic trigger for payers. Don't do it. If you are using modifier 25, your documentation must definitively show a separately identifiable service. That means no cloning notes from previous visits. Also, strictly observe your timing. Billing a Medicare AWV even one single day before those 11 full calendar months are passed will result in a fatal frequency denial. Always, always verify eligibility dates before the patient even walks in the door. Knowing the stark difference between commercial age brackets and Medicare's rigid G-code timelines is your foundation. But mastering the documentation to actually justify medical necessity when applying modifier 25, that is what truly protects your practice's revenue. Keep those audit trails clear, keep your notes individualized, and stop leaving money on the table just out of fear. Are you ready to audit-proof your next wellness visit, or are your super bills still a ticking time bomb? Don't forget to like, share, and subscribe to Decode Healthcare with Harshaw.